to our area of inquiry today. Mary McWilliams is the president and CEO of PacifiCare of Oregon and Washington. In this position, she's responsible for overseeing all aspects of the managed healthcare organization's operations throughout Washington, which currently is serving over 100,000 prepaid and 40,000 self-insured members, and the Northwest region's other prepaid plan with a combined enrollment of close to 300,000 members. Mary is also responsible for PacifiCare's distribution of specialty projects for managing mental health, pharmacy, wellness, dental, and other services. And 1995's combined revenues were over $400 million. Mary has over 2 decades of managed care experience. She received her master's in health administration from the University of Colorado, and she currently resides in Seattle. And we miss you, Mary. Stephen Gregg is the president and founder of Ethics, a Portland-based health insurance company, which was cited 3 years in a row by Money magazine as one of the fastest-growing companies in the nation. Mr. Gregg sold Ethics in 1994, that's spelled E-T-H-I-X, and founded a new insurance company named Alternare, which I understand means choice in Latin, which is fundamentally different from other area health insurance companies. His approach encourages choice and wellness incentives, and he is opposed to many aspects of managed care. Alternare combines traditional, that is Western, approaches to medicine with non-traditional Eastern health providers in the plan. Members can choose an MD or a naturopath. It's up to the subscriber. Alternare is built on the principle that patients are in the best position to decide whether they would prefer to go to the Mayo Clinic or whether they'd prefer to go to their favorite acupuncturist. Putting questions to these two from the patient's perspective is Barbara Lee Glidewell, RN, MBS, who has held the position of patient advocate and ombudsman at the Oregon Health Sciences University for the last 18 years. Mrs. Glidewell recently received a postgraduate certificate in medical ethics from the University of Washington, and she serves as assistant director for OHSU's Center for Ethics in Healthcare. Mrs. Glidewell's duties as patient advocate for university hospital and clinics involve her with conflict resolution, formal grievance resolution, risk management, death and dying issues, and other ethical dilemmas. She facilitates patient care conferences on issues of quality of care, discontinuing or limiting life support, assisting families to understand the ethical issues involved in those decisions, and to reach consensus. She mediates disputes between staff as well as patients and providers. Mrs. Glidewell is also a designated organ and tissue requester for the university, and in addition to providing bereavement support for families of dying or expired patients. She's a member of the university's domestic violence consult team and a member of the university's labor management committee. Russell Baker would set the stage for our panelists thusly, and I'm quoting, President Clinton abandoned his health care bill. The Democrats abandoned the president and connived with the Republicans to treat the health care matter as if it were a matter of caring for the insurance industry. And here we are, water 6 feet high and rising, and everybody out to lunch in New Hampshire, quoting Russell Baker. So Mary, you begin for us. Are we out to lunch in Oregon?
Well, first of all, I consider it a great honor to be back at City Club as a speaker. From a distance now, I'm even more convinced of what great contribution City Club makes to the life of Portland. It truly is the conscience of the city and contributes to rebuilding a sense of community. I note I recently heard a speech by David Brewster, who's the publisher of Seattle Weekly and Northwest Best Places, and he talked about the need for a stronger sense of community and civic mindedness. And later I suggested to him that this would be a good topic for a Friday program at City Club. And he said, oh, Portland doesn't need this. So it's true. I mean, Portland has great civic mindedness, and I think that that City Club is very much a part of that community. I think that we in Oregonians and in Portland have a lot to be proud of. I think the combination of prudent stewardship and progressivism have made Oregon a leader in a number of issues, whether it's land use planning or the bottle bill or health care. With respect to health care, I think the results speak for themselves. Our per capita health care costs are rank low. We're 41st out of 50 states. We consistently rank in the top 10% of measures of hospital efficiency, whether you look at length of stay or cost per day or the use of the hospital made by the population. Average family health care payments are 5th lowest of every state. And in my view, not unrelated is our leadership in managed care penetration as well. Oregon is among the top 5 states in terms of HMO penetration, with about 40% of the population in an HMO. Even a recent Lewis Harris poll reported in the Oregonian this week reported that Portlanders are satisfied with the cost and quality of care in the midst of all this managed care penetration. So why do I think that HMOs have been attractive here? Certainly the long history of Kaiser and the pressure that its pricing exerted on the private market to change contributed to the provider's willingness to change in order to compete or risk losing market share. I think we should also give credit to those leaders and provider groups who recognize that kind of the business as usual wouldn't be viable in the new price-conscious purchaser environment. And speaking of purchasers, I think Tektronic's leadership in stepping out to offer an alternative to Kaiser in 1986 gave the imprimatur to HMOs of Oregon's largest private employer that began the movement of employers into more forms of managed care. And so why is managed care necessary anyway? I'd say for the 20 years that I've been in healthcare, there's been a growing recognition that the U.S. healthcare system is broken. Our per capita healthcare costs are the highest of any industrialized country, but our health status indicators are no better. 15% of the population is uninsured, and healthcare costs have been rising at a rate that's twice as fast as the Consumer Price Index, consuming 15% of GDP, more than education, more than defense. Several years ago, when Alice Rivlin was head of the Congressional Budget Office and defense cutbacks were beginning, she wrote a column and talked about, instead of talking about a peace dividend, what would happen if we had a health dividend if we weren't spending as much on health care. Medicare is projected to be to be bankrupt by 2001, and Medicaid cost increases are even threatening states' bond ratings. The cost of health care is eating into corporate profits, threatening global competitiveness, and workers' salary gains have been siphoned off into increased health care premiums. Public and private purchasers and consumers are exerting the same pressure for value in health care as they have in other sectors. It's my view that the U.S. healthcare system is not a system and that health care is not in a budget. It's the 3rd largest industry, but really has largely been a cottage industry. Doctors and hospitals have operated independently, and as such, each has been oriented to generating its own revenue rather than managing fixed resources for a population. The insurance system has insulated providers and consumers from the cost implications of their decisions. Services have been oriented more to treating illness than promoting health, and it's difficult to pinpoint, much less even measure, the overall accountability for the quality of care. So I think that the U.S. healthcare system is large and complex, and I think it needs to be managed as an organized system of care. The analogy that I would draw for managed health care would be to the hardware and software systems. You could view the doctors and the hospitals and other providers of care as really the hardware, and in my view, HMOs kind of provide the operating system that knits together the providers to serve purchaser needs. And the software applications then are the various products that HMOs offer to customers. As with any complex system and set of transactions, a variety of tools are needed to manage both the cost and the quality. HMOs integrate multiple approaches to affect the cost and quality equation. One way for me to describe these approaches is to borrow some terms from a physician who wrote a book about ways to influence physician practice patterns. Many healthcare cost containment strategies are focused on physicians because although physician payments make up only 20% of healthcare costs, the services they order for patients constitute about 80% of health costs. It's been said that the most expensive piece of medical equipment is the physician's pen. Dr. John Eisenberg, who wrote this book, delineates the following 4 approaches. First, education and feedback. Secondly, participation in decision-making. Thirdly, administrative rules. And fourth, incentives and penalties. Dr. Eisenberg examined multiple studies about the effectiveness of each of these approaches in changing physician practice patterns, and he concluded that no one approach in isolation is as good as all in combination. So too, I would suggest that managed care can best address the challenges of cost and quality in the U.S. healthcare system by employing all of these tools with providers and with consumers. So let me describe what that means. One, with respect to education and feedback. In an organized system of care, both providers and consumers receive information to help them make decisions. HMO members are informed about how their health care plan works and how to access the healthcare system. They may be given self-help books and videos and even participate in health assessments to identify lifestyle changes that could improve their health. Physicians, then, they also receive data from health plans on their practice patterns relative to other physicians, and this can help reduce the range of variation in practice, which is characteristic of physician practice, but has shown no correlation to health outcomes or quality of care. Now, scientific outcome studies are being conducted and results are shared with physicians to help guide treatment decisions. So that's education feedback and how we use that with both parties. The second approach is participation in decision-making. Physicians in HMOs typically participate in committees which review the appropriateness of treatment in an individual case or develop guidelines for treatments of types of cases. Patients participate in decision-making too, as they discuss with physicians various treatment options. Primary care physicians tell me that they spend more time explaining treatment options to patients in prepaid care than in fee-for-service. Patient participation can even include such things as interactive videos to consider treatment alternatives, such as Dr. John Wenberg at Dartmouth Medical School in New Hampshire has employed to consider treatment options for prostate cancer. Thirdly, administrative rules. For physicians, that could include such things as a pre-authorization process for inpatient admission. Such rules are designed, as much as anything, to prompt the physician to stop and think about what the most appropriate next step would be in the care of an individual patient. For the consumer, the requirement to choose a primary care physician and to receive a referral for specialty care could be classified as an administrative rule. We do believe that this process ensures that patients get the right care at the right time in the right setting. While the selection of a primary care physician may be a rule, we also believe that quality care begins with having a choice among qualified physicians and the freedom to change physicians. More and more health plans are also responding to consumer interest in having access to alternate providers as well. Fourth, incentives. Incentives for HMOs include making preventive and routine care affordable with only a modest copayment to encourage early diagnosis and treatment. Alternately, a higher copayment may be levied for use of the emergency room as a penalty to discourage inappropriate use of this high-cost setting where ER doctors may not have access to a patient's entire history. HMOs generally avoid high deductible and coinsurance plans to allow members to budget and predict their healthcare costs and to encourage early intervention before a condition deteriorates and becomes more debilitating and then more costly. Medical savings accounts aren't as compatible with the HMO philosophy of care. They favor the wealthy to whom the tax deduction is worth more, and they leave a small base of people to support the 6% of patients who account for 70% of healthcare costs. Putting too much financial responsibility on an individual may penalize the person for whom genetic or socioeconomic determinants of ill health over which there is little or no control. The capitation payment approach, which in general establishes a budget for health care for enrolled members, provides an incentive for primary care physicians to get to know their members before they become patients, to apply proven preventive measures like immunizations and routine health exams and pap smears for women, and to intervene early to treat problems before they become more serious and more costly. Capitation compensates physicians for all the services they provide, like telephone consultation following treatment or outreach to at-risk individuals, not just those services for which the insurance program typically pays for. Capitation payments are based on expected cost of care for groups of members and are usually buffered by stop-loss provisions which cap physicians' financial responsibility so as not to deter needed care or penalize physicians for catastrophic patient. Physicians know that if patients aren't satisfied, they'll change doctors, and that's an incentive too. HMOs quality management programs do case reviews and review patient care patterns of physicians to monitor underutilization as well as overutilization. And finally, savings from lower use of services are usually spread over groups of physicians so that an individual physician isn't really specifically rewarded for individual treatment decisions. Consumers do have the right to know how their health plans work and how providers are paid. And to that end, new Medicare regulations for HMOs will ensure that plans disclose their physician compensation methods to members. I would conclude my case for employing all the tools of managed care with providers and purchasers, education and feedback, participation in decision-making, administrative rules, and incentives and penalties with the facts about members' experience with HMOs. Study after study has shown that the quality of care in HMOs is as high and in some cases higher than in the fee-for-service indemnity system. Surveys of HMO members report high levels of satisfaction and affordability. People are voting with their feet. 50 million people, or 20% of the population, are now enrolled in HMOs, and I expect that to continue to grow as managed care continues to evolve to meet the needs of Americans.
Thank you, Mary. As moderator, just a brief comment that I'm asking the audience to help me keep us honest. So Steve is next. Steve, please come forward.
Well, I'm honored to be here and with Mary and take on the assignment of offering some criticism for what is I think an overwhelming trend in healthcare reform, and that is the growth of managed care and HMOs in particular. I was a hospital administrator in Minneapolis, where I started my career, and was at the hospital that executed the first HMO contract in the Twin Cities. And so I've been in this for some time, and personally led the efficacy of negotiating the cost of the healthcare product between employers and providers at a time when most providers believed that was a very, very bad and sinful thing to do. The tribute I will give to the managed care and HMO industry is that I think probably 75 or 80% of what we know about medical economics has really come out of the pursuit of managed care. I look at pre-HMO period is that we really were a nation of nitwits when it came to economics of healthcare. And we've really, as a result of that kind of programming, I think we've become much more introspective as to what the healthcare transaction is all about. So the theory I hold, as I've watched the industry, my attack is not so much on HMOs per se, is more the societal assumptions that create managed care, and I think those deserve some reflection. And the question is, in my mind, not as what is your HMO doing for you today. It's really, is this the position as we project ourselves 10 or 15 years out that we think we're all going to be happy in that environment. And as you look at assumptions, I think assumptions drive everything. If you control assumptions, you control the solutions. And I think the debate on this subject has always been a debate about assumptions. In the 1950s, we felt with some passion the reason why we had inordinate healthcare costs at that time was because we had too few doctors and too few hospitals in the country. And by policy, we proceeded to double the enrollment of medical schools and build up hospitals far beyond what anybody debates today as being an excess capacity situation. In the 70s, when I became involved in the business, we developed a passion about things called certificate of need and community planning. And the premise behind that was that if we controlled the allocation of capital, we would control healthcare costs. And if we went through very elaborate planning processes and carefully allocated where the CAT scanners went, we would control costs. And we ended up dismissing that characteristic. And now we're into another arena, in my mind, of assumptions that create products called PPOs, HMOs, the like, if you will. The assumptions that I interpret, I have about 15 or 16 assumptions that I wrote down that I had some problem with or would like to challenge. And I think you as rational people, you would join me in at least thinking about these assumptions. I really have three that I want to put before you, which, again, if you change these radically, the product that you would be offered would be different than what it is. The first one is we have a healthcare system, and these are really, I think, more somewhat explicit or perhaps more implied things, but we have a healthcare system that is chiefly financed by other people's money. I call it OPM. And there's a great deal of confusion about whose dollars actually buys healthcare services. Employers would be heard to say it's my dollars that buy healthcare. We're now even to I've had some dialogues with primary care physicians that would lead you to say that when you go to a specialist, it's my dollars as a primary care physician that's buying that specialist time. So there's a great deal of confusion and ambiguity about whose money actually buys healthcare. And that begins the travel down the road of where the accountability lies in this business. Specific to a classic HMO design is the $5 or $10 copay. You were really, I remember in the early days, you were actually marketed that you didn't have to care about how much the costs were, that this was a highly convenient system. You didn't get a claim form. As a matter of fact, if you asked how much the costs were, and this is still true today, you might expect that you have a problem finding out what the cost would be. And I think the idea that you can come in and present a $5 or $10 sum of money on the table, expect $600 of service as a very aggressive consumer, and not give a twit about what the costs are, that to me is problematical in terms of a positioning issue. Secondly, I'm detecting a movement of, and I think this came up in the Clinton reform debate, that we're developing a belief that the system and the providers are actually more responsible for my health care than I am. And that there's a system out there that I'm really a piece of flesh here, and if I present myself to the system, it really has an obligation to take care of me, and it has an obligation to create the kinds of outcomes I would expect. I'm of a belief that no one can assume more responsibility for one's health care than the person seeking it. And I suspect, I'm concerned that we're in a process where we're insidiously eroding that responsibility. And it's happening over a long period of time, and we're not necessarily making note of it. There are people that want to advocate this position, but that will say that up to 60% of the demand in the healthcare system is individual lifestyle-related demand, and that you presumably control through your own decision-making. So I have a problem with that. Thirdly, the third assumption is that, I didn't really, I was on this side at one point in time, but for a while I believed the song of managed care that the choice has to be limited in managed care for this whole game plan to work. And yet, in all other aspects of our life, I think we would generally believe the way we get to a better product long term is to expand consumer choice. In the Clinton reform rhetoric, the clear scenario on the table was to see very, very large consolidation of healthcare systems in a given community, such that a community like Portland would reduce itself to 3 or 4 health plans that you would be effectively obligated to get your health care from. Basically constraining choice. You would participate in a plan, as was referred to, that if you decided you needed to go to the Mayo Clinic, you may not be able to go there and expect any kind of financing. Closed plans. In the managed care business, and again, I'm biting at my own wrist here because I'm not criticizing. I was in this business. The culture of the vendor side is sort of the last thing you want as a consumer on the loose. You really you want a sense of rules and a tightness to the system because it is your mandate, to control the cost. So you end up with I think you end up with somewhat of a command and control type of mentality. And so I think in this equation, you say, is this a long-term play? I mean, can I really advance a system where the consumer has no particular economic alignment with the plan? Can I advance a system that views consumers as inadequate in terms of their capability to make judgments by themselves? And can I advance a system where we're trying to constrain choice rather than expand it and still believe that that is in fact the best position to be in long term? I question that scenario. No question that managed care is mitigating the current expansion of healthcare costs right now. But the people I talk to sort of wonder, what's the play, what's the generation after you strip down the initial fat of the system. Thank you.
Thank you, Steve. Well, we obviously have point and counterpoint here, and it's really exciting to hear the two perspectives. Managed care is really reshaping the culture and the practice of medicine in America. We've sort of jettisoned the old concept of the Marcus Welby MD style for something entirely new where doctors are gatekeepers. And is that a dirty word? Patients become covered lives. And often remote case managers are deciding whether the patient gets a certain treatment or does not. So it's a seismic plate shift in the 80s and the 90s as seismic, Steve has suggested. Patients don't wake up in the morning anymore necessarily and say, I've got a pink eye, I'll go see an ophthalmologist. One contacts your managed care primary provider first to determine if that's appropriate, or does the primary provider manage that for you? So it's really a sensitive notion that we've all been raised on in this American culture, that even the most expensive and esoteric treatments should be available to all. I'd like to ask 2 questions of each of our panelists, and I'd like to begin with Mary. Mary, since the new medicine has really replaced the admittedly flawed fee-for-service system with capitation, do you think there's a risk that the interests of the doctor may come into conflict with the interests of the patient?
Well, first of all, I know that physicians are trained and take an oath in terms of putting the patient's interest first, and I believe that physicians are ethical and oriented to make the best decision for their patients. I think that there is certainly that potential for not being in total agreement, but I think there are a lot of checks and balances on that. One is, as I said, people can change doctors. I think lost my train of thought. That the kinds of safeguards that I talked about in terms of systems within HMOs to make sure that there's oversight of what the physician does and what care the member gets. Arrangements that kind of buffer the financial incentives that can mitigate that. And so I think what you try to do is set up checks and balances to ensure that there isn't an adversarial or inappropriate relationship between the two.
That's what I wanted to hear you say. Going along with that, Mary, a second question is, why do you think the gatekeeper concept would be so offensive to medical consumers?
I prefer the term case manager.
Okay.
I think that, I look at having a personal relationship with a physician who knows me and my healthcare needs, and I even happen to be a family practice devotee, so my doctor knows the whole family. I know when I had a little baby and I went in with that crying child that it was my doctor too. It was very reassuring. So I think that that really what we are talking about is establishing a relationship with a personal physician who can help understand your total needs and try to guide you through the system, because I think it is a complex system. I think that clearly the patient options or the treatment options need to be discussed between the physician and patient, that it shouldn't be unilateral, it shouldn't be directive, it shouldn't be this is what you're going to do, but that that in that kind of environment, that it should not be a negative, feature, and that having that kind of care manager is really a positive force in somebody's health care.
And that's good to hear, a positive force. In keeping with that, Steve, I wanted to push that envelope a bit further. You were talking about the risk equation. Do you feel that the average medical consumer is really ready to take on a responsibility for their own risk factors?
Well, I think a lot of people would. I think we have an environment that would beg the question, why should I in this current situation? I know a lot of people enjoy getting their health care for free and enjoy the convenience of not being confronted with the actual costs of the health care and being involved in that transaction. I think we also have an absorption with equalness of benefit, which I don't think makes a lot of sense. If we all come from broad economic circumstances, in the car insurance world, I'm sort of sitting there saying, how big of a deductible can I afford? And I'm looking for that kind of an option. And I try to drive my premium down by taking more risk. And yet we clearly in healthcare, we're on a track of saying we ought to minimize, regardless of your economic standing, we ought to minimize a person's individual risk. I think some individual risk is the necessary lubricant to making sure the individual is properly aligned with the total economics of the health plan.
Thanks, Steve. I have an important question relative to my own interests in academic medical center. I was wondering, Steve, if you could comment, in light of the difficulties of the academic medical center to compete in this managed care environment with the high cost that the academic center has in terms of running its ship, what strategies would you suggest, Steve, that the academic centers could do that would be different from the other major medical centers in a community?
That's a question that's confronting virtually every academic medical center in the country. If you're plugged into this business at all, you understand there's the knees are knocking heavily within those environments in terms of the impact of managed care, because the typical managed care organization, for a lot of reasons and not just economic, would prefer not to deal with academic medical centers as the mainstay of how they get their care provided. I think a much bolder, I get the impression when I talk to not here, but in other places, that the general strategy is to continue to chase how those institutions will be involved in managed care organizations. And I think it's going to be that's a tough strategy. And I think I would tend to look to a more dramatic and differentiating play than simply how can I be a part of the managed care trend. And I specifically think of this very contrarian concept called medical savings accounts, and would challenge academic medical centers to think about how they might participate in that intellectual thought, and how compatible it would be with their mission. but there may be other programmatic approaches. I just sense that they're going to in general, have a very tough time catching up on the managed care train.
Well, thank you. Final question for Mary before I turn the podium over to Christine. Where the patient fits into this equation is a concern for all of us because at one time or another, I think we're all patients. So I want to ask Mary, how do you feel the principle of autonomy fits into this managed care equation?
Well, I probably prefer the term shared accountability. I think that neither providers nor consumers should be totally autonomous because partly I think we need to have organized systems of care and everybody doing their part. We can't just kind of work in isolation. And so I would hope that there be shared accountability among the patient and the providers to really arrive at the best course of treatment.
Thank you. Christine.
As I mentioned before, will be Doug Marker's privilege to ask the first question. I just wanted to remind you, as much as we appreciate access to these individuals to air whatever concerns we may have personally about our health care, I hope that in the questions, I know, Doug, you won't do this, that you will look at the overall issues presented in the program.
Well, actually, that took away my first question. An ache in my shoulder. Well, what I was trying to focus on was in the discussions of changes in the way balance of risk is provided in healthcare and discussions of capitation, medical savings plan, is it accurate to perceive that what's really happening is that the financial risk is moving, or at least the burden of the financial risk is moving away from insurers and more on to doctors and the patients? And if that's true, is the quality of care being affected by the shift in that financial risk?
I'll make the first comment. Historically, insurers were just money handlers and claims payers, and there was a separation between the payment for health care and the delivery of health care. And I think what we're trying to do today is to share that financial responsibility both with the insurer or the health plan and the provider. And actually, I think that there is a benefit if you look at the ultimate form of kind of that risk sharing through capitation, where rather than having an insurer with a $1-800 nurse make a decision about whether care is appropriate, that physicians would make those decisions. And in our plans, we have committees within our medical groups that consider individual cases and make those decisions about what's appropriate based on a thorough knowledge of that individual, as opposed to having the payer be somebody remote who really tries to second guess across 800 miles what's appropriate. So I think it really does place decision making more in the hands of physicians, which is, I think, where it should be, and that, I believe, will enhance quality.
Well, you added consumer. I think generally over a period of time, the consumer, for us that are insured, is incurring less risk as we have more mandated benefits, and generally the 80-20 insurance plan is disappearing and was generally a more expensive benefit design from a consumer's perspective than the typical managed care design. So the consumer, I think, is in exchange for this commitment to a fixed system, is generally, I think, catching up with more benefits than perhaps they had before. My concern about the transfer of financial risk to the providers is again the development of the perception that the vendor side of this equation, that it becomes their money, and that the patient, again, not intended to be so, and among professions, I think physicians rank right up there as being among the best. But the patient, I worry about the patient becoming a cost center, if you will, rather than a client in that relationship. That you become one of many patients that the system has to take care of in totality. You know, there's this argument of, do we have an individually based healthcare system, or a system that seeks its accountability as to how it does in general for the population? I worry about that latter strategy, because as Mary pointed out, at any given time, only 7% of us are really sick. So, and I think that's a worthwhile debate. Is where do we want to find this balance between individual interests and system interests.
I would add, relative to the consumer base, consumers walk into the physician office wanting to get their needs met, and they may not realize that there's a new dialogue and there's a new way to talk to your managed care provider. Consumers realize that they have so much time with the provider, but that they have to get their needs met in a triage order. So we need to educate the consumers on how best to talk with their doctors and utilize this new opportunity.
Andrew Glazer, City Club member. Many members of managed care organizations are anxious that their personal opportunities for health care are being compromised at the expense of bonuses and financial incentives to providers, margins and high salaries to payers, insurance companies, and reduced costs to the purchasers. What words of wisdom or solace would you have for the people who have those anxieties?
Well, first of all, I think obviously there's been a lot of coverage in the press, and one of our industry leaders talked about kind of attack by anecdote, and I think there are always examples of egregious behavior or things that aren't appropriate that can occur, but what solace I take is the numerous studies that have been done that document the quality of care in HMOs, the patient satisfaction of members, the value that's being delivered for the purchaser and for the consumer. And while I acknowledge the anxiety, I think we need to be responsive to that and to be accountable for how prudently we use the monies and how good the care is, but that to be aware that there are other, high-profile stories sell magazines, and so we're apt to see more of that may be really reflective of what's prevalent in the industry.
I'm Bob Shoemaker, member of the club. Both of your arguments, I think, have a lot of validity, but I wonder if it has to be one or the other. That is, either individual responsibility for your total care or collective managed care responsibility for your total care. Strikes me that we could have a system where you have individual responsibility up to some fairly high level of each year, like $3,000, with managed care coming in at that point for your more serious incidents. I'd like both of you to respond to that, if you could.
Yeah, I've been asked that question a lot, and in the end, I like to find the middle ground, like anyone, but I think that the key issue is to force yourself intellectually to say, which of these two positions do you want to depart from? Is it do you want to depart from a system-based thinking, and then we're going to tell you consumers out there to stop smoking as the system, or do you want to start from the perspective that the individual is central to this thing? I favor very much I think we're overinsured. I think I'm looking for benefits to be expanded to toothpaste here in a little bit, but I think we're way overinsured, and that the MSA concept of having the consumer's money for the first $3,000 you mentioned, I'd like to think over a lifetime I might be able to assemble $50,000 so that when I get to age 65, I could buy a policy that would be expensive with a $50,000 deductible in it, and in that way, I'm not passing with the intensity I am the cost of a Medicare product to my kids, and that's a better future for me than the alternative.
I think my concern about having kind of the high deductible and then opting into managed care is a lot of decisions are made by that point. You're in the course of treatment, you have a series of physicians, and to kind of late in the stage to then opt into a system, I think would be difficult. And I think people want to be able to budget and predict for what their costs are. And maybe this MSA would allow someone to have modest kind of front-end payments. But I've had people express concern to me about 50% co-payment levels that could leave somebody with a $500 bill who's making $15,000 a year. So I think we have to be aware of the risk tolerance and the ability of someone at a lower income level to really kind of handle the volatility that can happen in expense.
I'm Dr. Jörn Horneman. I'm a member of the City Club and also the Oregon Medical Association. And I had the honor to be a delegate to the Ashland Conference, which is the annual conference, where they passed a motion which I think is germane to this discussion. And the motion went, resolved that patients should have the right to receive from their insurer the contract between the insurer and their physician. Now, the concern that the doctors have, and that was expressed, was that in the prospectus, there is no mention of capitation and its negative and lack of incentive to provide care. There was no mention of the risk sharing or gatekeeper or case manager, which provides a financial disincentive to refer. In fact, it is a financial penalty if they refer for a second opinion, if they refer to a doctor who is better qualified, if they perform investigations necessary to prove their diagnosis. Now, my question is directed to you, Ms. McWilliams. What plans do you have for curing the deficiency in your brochure? And if you haven't got any plans, why haven't you? And when are you going to send out with the application a copy of the contract between yourselves and the physicians? I think you should understand you're on candid camera.
As I mentioned, the HCFA, which really regulates Medicare HMOs, has just issued regulations that will specify the kinds of information that must be distributed to members. And we will do that, and happily so. And I think the reason that HMOs haven't done a lot in terms of educating members about payment systems is that it's been hard enough to get people to understand what their benefits are and how much it costs them, and how to, choosing a primary care physician, given limited kind of attention. So I fully support the efforts to kind of disclose more to members and to make sure that they understand, as I said in my speech, what the requirements are and how physicians are paid and the like. And I think you'll see very shortly, I think it's the 1st of January, when the regulations go into effect, that all the plans will be describing how physicians are compensated and incented, and to make sure that they have all that information.
When you're talking about the ability of patients to make a decision, you're talking about we, the people, who elect our own leaders, have done very well for the last 200 years.
Thank you.
I'm Joe Nadal, a member, also a retired surgeon. I was in the Portland Clinic, enjoyed my work for 44 years. I've been retired 10 years. I'm now a patient. Not a very sick one. Before I retired, I was just getting used to the term provider, which I didn't like particularly, and then the term vendor, which I thought was terrible. But I'd never been called hardware before.
Yeah, no, I know. Yeah, I
know. And of course, the joy of practicing surgery or medicine had a lot to do with what our speaker a week ago said. And that is the meaning. I won't repeat it because everybody here heard it. I'm keeping up contact with physicians as well as being a patient. I go to St. Vincent maybe once or twice a month and go to the conferences, surgical conferences and so on. Occasionally I have lunch at the Portland Clinic where I used, so I still have the input from physicians and the experience of being a patient. And what I'd like to know is, in the software that you spoke of, do you have some physicians, some caring physicians, that really understand what this means to everybody?
Great. First of all, I wondered about that reference, and I apologize, and I mean no offense. I hold physicians in hospitals in very high regard, and I'm perhaps trying to describe more what we do than what you do. But I'm very proud to say that at PacifiCare, we have a general manager who's the resident day-to-day leader of our plan, who is a physician executive. Bart McMullen was a practicing physician at the Suburban Clinic, the longtime vice president for health affairs, and most recently has been promoted to be the general manager. And one of the attributes that he brings to the position is the the understanding of what it means to treat a patient and the importance of ethical care. And he is the most ethical, highest integrity person that you can imagine. So we feel very good that we have a physician executive leading the organization. We also have a full-time medical director, and we'll be recruiting another one. So we've tried to take that influence very strongly. So thanks for giving me the chance to give him the credit.
Excuse me, Monroe, this will have to be the last question. I'm sorry, Ray and others.
My name is Monroe Sweetland. I'm a member of the club. My father was a doctor. I can't qualify with the rest of the lineup, and I thought you were about to tell me that I couldn't ask my question because I wasn't an expert. I was quite surprised to have the prelude to our whole discussion today begin with the announcement that President Clinton had given up. He didn't surrender. He certainly was surrounded. But in a different climate, just a few months from now, with no more Speaker Gingrich and no more freshman majority in the House, things can be very much different. I'm asking this question. I see among many complicated problems here a number which have to be decided ultimately by the people, as the doctor suggested a minute ago, and included among them are the conflicts in the profession. I'm a Kaiser customer, and I like it. And we get to know our doctors, and we get to know our attendants. And I think Kaiser has a great high percentage of satisfaction among its customers. But now there's a serious cloud on the horizon. And the nurses, through their strong organization and effectively led, are raising some of these questions. Are they going to be factored into the decision-making? Is it only going to be the doctors and the insurance companies that make these decisions? And what do you see as the role of that very good group of professionals who are now in full cry against the squeeze that they're feeling as the HMO perfects its organization, its system? Is that a legitimate question?
Oh, I think it's very legitimate. I think, again, compared to many years ago, I think the circle of who's involved in decision-making in the healthcare environment has clearly expanded to include nurses and the many professions that are in the industry. I mean, the old scheme was it was a pyramidal organization with the king at the top who had an MD after their name, and my detection of the industry is that a lot of that has broken down, or most of it has broken down, and hospitals in particular have expended considerable efforts to create a team environment that includes all the professions that would be involved. I'm not sure what the source of concern is at Kaiser per se, but generally the industry, I think, has made a lot of advances in that regard.
Could
and
I
think
have
the
Mary's
physicians
response to that too?
I think that Steve did a great job. We have nurses as part of our organization, but I think it needs to it's part of the shared accountability to have contributions from all the sectors.
I'd like to thank our panelists for helping us put these issues in perspective and making us smarter healthcare consumers. And I would ask all the listeners on radio and here, what do you think? Is it still possible to be both healthy, wealthy, and wise? And as you ponder that, I will declare us adjourned, but I will see you next week, remember, at the Red Lion.
Barbara, thank you. Hi.
With the VNA Healthcare Report.
Okay, sure. How are you?